Welcome to the deep dive. Today, we are immersing ourselves in the body's ultimate survival strategy.
We're talking about the systemic and often invisible reaction to trauma.
Right, or major illness, or even the controlled stress of elective surgery. This isn't just about the wound itself.
No, not at all. It's about the full, complex physiological war that just erupts throughout the body.
Well, what's universally known as the metabolic response to injury.
And we're taking on a challenging source today. Our guide is the definitive textbook for surgical trainees, Baily and Love, Basic Principles, specifically Chapter 1.
That chapter on the metabolic response, for anyone, preparing for acute care practice, this chapter is foundational.
Foundational, but it is dense. Very dense.
Exactly. So our mission today is really a deep analysis and interpretation. We are not, and I want to be clear, we are not replacing the requirement to read that excellent text.
Which you absolutely should.
Absolutely. But we are structuring it, providing the key anchors, the metaphors, the context that turns pages of biochemistry into a clear, usable, ready reckoner.
For revision, for understanding. And this is so critical because for surgeons and critical care teams, understanding this metabolic upheaval is, well, it's the difference between success and failure.
It really is.
These metabolic effects dictate the speed of recovery. They profoundly influence the risk of complications.
Especially those devastating conditions like sepsis and multi-organ failure.
And ultimately, they determine long-term survival. Modern care is all about managing and actively minimizing this inherent stress response.
Okay, let's unpack this then. We have two foundational concepts we have to establish before we dive into the chaos of it all. First, homeostasis.
Homeostasis is, simply put, the continuous process of maintaining a constant internal environment.
So keeping temperature, pH, blood sugar, all that stuff stable.
Exactly. Keeping all those chemical balances just right to ensure optimal cellular function.
And trauma, sepsis, or surgery just destroys that balance immediately.
It shatters it. The metabolic response is the body's emergency attempt to claw its way back to stability, even if the tools it uses are highly destructive in the short term.
And the second concept is the traditional sort of historical view of the response, which is biphasic. It has two phases.
Right. We traditionally view the process in two major phases. The first is the catabolic phase.
The breakdown phase.
The immediate crisis management period. It's defined by biological breakdown, energy mobilization, and often shock. This is emergency mode.
And that's followed by
the anabolic phase, which is the long-term period of genuine repair, rebuilding, and restoration of tissue integrity.
So knowing which phase your patient is in is really the first step toward effective management.
It's the first and most critical step.
Let's start with that alarm phase then. The catabolic crisis, or what we can call the body's emergency lockdown. This sequence begins instantaneously upon injury.
Instantly.
What is the singular overriding purpose of this radical system-wide shift?
Survival. Short-term survival is the only priority, especially if the injury involves, say, blood loss or severe tissue damage.
So the body just hits the panic button.
It does. It prioritizes the integrity of circulating volume and mobilizing stored energy immediately. Everything else is secondary.
And the characteristics we see in this initial catabolic or ebb phase, as it's sometimes called, are exactly the symptoms of an overwhelmed system, aren't they?
They are. The medical text describes this phase, which often includes shock, as having hypovolemia, a decreased basal metabolic rate, or BMR.
So the engine is actually slowing down at first.
For a moment, yes. You also see reduced cardiac output, hypothermia, and lactic acidosis. The immediate neurohormonal responses that accompany this then trigger the systemic inflammatory response syndrome, or SIRS.
And this is where the body begins what is often described as, autocannibalism.
Essentially, yes. SIRS forces the body to mobilize its internal stores aggressively. You see immediate muscle breakdown, proteolysis, significant weight loss, and critically severe hyperglycemia as the body just floods the system with glucose.
And this mobilization is intended to provide fuel and building blocks for repair, right?
It is, but the stress it places on the system increases the risk profile exponentially.
And while it's necessary for survival, the catabolic phase is the one we spend all our effort trying to minimize and get the patient out of.
Correct. If the patient survives the initial injury and the catabolism stabilizes, they transition into the anabolic phase.
The flow or rebuilding phase.
Right. For a minor injury, this is quick. But after major trauma or, say, massive burns, this painstaking rebuilding process can last for weeks or even many, many months.
Now, one of the most important conceptual points, especially for anyone using this deep dive as a ready reckoner, is understanding that the body's reaction is graded.
Yes.
It's not an all-or-nothing event.
That concept, and is illustrated beautifully in Figure 1.1 in the core text, is absolutely foundational. The metabolic response is directly proportional to the magnitude of the insult. You have a clear spectrum.
Okay, so let's take the low end, a clean, minor elective surgery.
In that case, you get a transient, modest bump in parameters, a slight rise in temperature, heart rate, respiratory rate, overall energy expenditure, and a white blood cell count.
A temporary signal the system handles easily.
Exactly. It's a whisper, not a scream.
But now let's amplify that stress severe burns, major trauma, prolonged overwhelming sepsis.
Now the changes become profoundly accentuated. This is where we see true, marked catabolism, hypermetabolism, severe SIRS, prolonged shock, and the imminent risk of multiple organ dysfunction syndrome, or MODS.
We are now in a life-or-death battle against systemic failure.
That's it. And that distinction between the immediate injury and the long-term systemic fallout is so vital. We often hear about patients who are successfully resuscitated from massive initial trauma, only to succumb days or weeks later.
And that's why.
That's because the late deaths in modern critical care settings often occur not due to the bullet or the crash, but due to the complex, uncontrolled physiological processes initiated by the stress response.
Namely, subsequent sepsis and MODS.
Exactly. We have to acknowledge that even with the best care, MODS mortality remains stubbornly high, somewhere around 25%.
And here's where the human element complicates things even further, the role of genetic variability.
Absolutely. The text makes a really important point of this. Even if two patients have clinically identical injuries, their individual inflammatory and metabolic responses can vary dramatically.
So my body and your body could react completely differently to the same car crash.
Completely. Some individuals are just genetically primed to mount a much more aggressive inflammatory response than others. This highlights the inherent unpredictability in managing surgical stress and why, one-size-fits-all approach is so challenging.
Okay, so let me just check my understanding here. If I'm tracking this progression from the initial catabolic emergency lockdown to the SIRS trigger, where the body is mobilizing resources and creating this inflammatory state, what is the biggest danger that emerges in this chronic systemic phase?
That is the crux of the problem. If that SIRS reaction is severe and prolonged, the greatest threat to the patient's long-term survival is the subsequent fallout.
Which is?
It's the combination of runaway inflammation and immunosuppression that leads to sepsis and multiple organ dysfunction syndrome, MODS. The metabolic chaos of the catabolic phase creates the perfect environment for infection to take hold and organ systems to crash. That is the ultimate battlefield.
So now we have to move into the actual drivers of this chaos. It's one thing to see the effects, high heart rate, muscle wasting, but what molecular signals are actually commanding these changes?
Right, what's happening at the cellular level?
Let's start with the purely cellular response to the inflammatory triggers.
Okay, so when we talk about cellular triggers, we need to introduce a really useful concept. Let's call them the body's cellular smoke alarms.
I like that, cellular smoke alarms.
When tissue is damaged, whether by crushing trauma or a clean surgical incision cells rupture, they burst open, and they immediately release molecular fragments into the environment that signal danger.
These are known as damage-associated molecular patterns, or DAMPs.
Exactly. So DAMPs are the non-living shrapnel, the wreckage itself pouring out of the destroyed cells.
Precisely. The wreckage is the alarm. And the text gives examples like heat shock proteins, HMGB1, SN100 proteins.
And fragments of nucleic acids that should always be tucked safely inside the nucleus. Their presence outside the cell is an unambiguous signal to the immune system that there has been violent injury.
And the body has specialized sensors, listening posts, to detect this shrapnel.
It does. These DAMPs are sensed by specific receptors on the cells of our innate immune system. Macrophages, dendritic cells, neutrophils. These are the pattern recognition receptors, PRRs.
Like the famous toll-like receptors.
Those are the best known examples. And when a PR detects a DAMP, it's not just an acknowledgement, it's an immediate call to arms.
And that call to arms activates this complex machinery inside the cell, the inflammasome cascade. Can you slow this down for us? What exactly is the mechanism here?
Right. So the signal from the PRR triggers the assembly of these complex intracellular protein platforms called inflammasomes.
Okay.
Think of the inflammasome as a highly sensitive bomb timer. Once it's assembled, The inflammasome activates specific enzymes known as caspases.
And the caspases are the final switch.
So the final switch that cleaves and releases the main chemical commanders of the inflammatory response. Interleukin-1, IL-1, IL-6, and tumor necrosis factor alpha, TNSA. This whole sequence is the initial, sterile, systemic inflammatory cascade that drives SIRS.
So we go from shrapnel, the damps, to listening posts, the PRRs, to the bomb timer switch, the inflammasome caspases, and then the chemical commanders, the cytokines like IL-1, IL-6, and TNF.
That's the chain of command?
What are the consequences when these commanders flood the system?
The consequences are, frankly, systemic devastation. You see generalized inflammation that increases microvascular permeability.
Leaky capillaries.
Leaky capillaries. This causes fluid to leak out, leading to tissue edema and coagulopathy. This compromises blood flow, which causes local ischemia, which tragically generates more damps, continuing the cycle.
A vicious circle.
And this runaway sterile inflammation is the primary risk factor for acute kidney injury, acute lung injury, and the direct pathway to MADIS.
I can see the inherent logic of the system, but the text highlights a massive conceptual roadblock for medical scientists who are trying to fix this. It's called redundancy.
Yes.
Why is that such a problem for drug development?
It's a hugely frustrating barrier. A single damp doesn't just knock on one PR door. It may activate several different receptors and multiple inflammatory pathways simultaneously.
So there's crossover.
A lot of crossover. This redundancy means you can develop a targeted drug to block pathway A, but pathways B, C, and D simply compensate and continue to transmit the inflammatory signal.
So the biological backup system makes a single magic bullet almost impossible.
It makes achieving effective therapeutic blockade against generalized SIRS incredibly difficult.
And the inflammation doesn't just stop once the initial wound is closed. The process can be prolonged or amplified by secondary insult.
That's right. The body's initial response can be maintained or worsened by a continuous release of damps from other sources.
Like
A new onset of sepsis, ongoing low-level hemorrhage, a massive transfusion of blood products, severe acidosis, crush syndrome, or the damaging effects of ischemia reperfusion injury.
where the return of blood flow actually causes a burst of damage.
Exactly. So if we treat a complication poorly or too slowly, we effectively amplify the inflammation and the subsequent immune dysfunction.
Okay, so if the dams are the sort of slow-moving cellular alarm, the body also has an almost instantaneous response mechanism.
The neuroendocrine axis.
This is the brain-body connection, and it runs on speed and hormones.
This is the rapid system-wide stress pathway. It typically kicks in within hours of the insult.
And it starts with the pain signals.
It starts with afferent nociceptive neurons, the pain and injury signals, racing up the spinal cord to the central hub, the hypothalamus.
And when the hypothalamus gets that massive distress signal, it acts as the master conductor.
It does. It releases corticotropin-releasing factor, or CRF, which immediately stimulates the pituitary gland to release ACTH.
Adrenocorticotropic hormone.
Right. ACTH travels swiftly to the adrenals, causing a sharp, rapid rise in cortisol levels.
And that's not all.
At the same time, the hypothalamus activates the sympathetic nervous system, the SNS, which unleashes a massive surge of adrenaline, epinephrine, and glucagon.
That trio cortisol, adrenaline, glucagon is often called the counter-regulatory cocktail. It sounds beneficial, but what immediate radical metabolic effect does it have on the patient?
It's designed for one thing: acute survival. The metabolic effect is the immediate mobilization of stored energy. It forces the liver to release stored glucose and accelerates the breakdown of fat and, critically, protein for use as rapid fuel.
The body is switching from normal operation to high-power emergency energy mobilization mode.
Instantly.
And beyond this main trio, what other major hormonal alterations are happening?
The whole system is reprioritizing everything. You see complex changes in insulin production and major sensitivity issues.
Insulin resistance, which we have to come back to.
Absolutely. There is also hypersecretion of prolactin and growth hormone. Now, GH is interesting because it's both beneficial in some ways, but it's also actively lipolytic, insulin antagonizing, and even pro-inflammatory.
And what gets shut down?
Crucially, the body deliberately suppresses peripheral thyroid and gonadal function.
Oh.
Long-term growth and reproduction are non-essential and are shut down immediately.
And the text is clear that this neuroendocrine response is also biphasic. The immediate benefit transitions into a chronic problem.
Yes. The acute phase, which is hours, with the surge of counter-regulatory hormones, is essential for survival, no question.
Yeah.
But this often gives way to the chronic phase, which can be days or weeks, and that's characterized by central hypothalamic suppression and low serum levels of the target organ hormones.
And that's a problem.
It's believed to be a significant contributor to the muscle wasting and general debilitation we see in prolonged critical illness.
Now, this is where it gets really interesting, connecting these two pathways, the cellular DAMPs and cytokine response, and the hormonal neuroendocrine response. They aren't two separate engines.
No, they're deeply integrated systems. Pro-inflammatory cytokines like IL-1, TNF, and IL-6 are the master conductors of the whole orchestra.
How so?
Well, they act directly on the hypothalamus, causing fever pyrexia, which is a classic sign of SIRS. They augment the hormonal stress response and, crucially, act directly on skeletal muscle to promote protein breakdown.
Can you give us a concrete example of this?
Sure. Take cortisol, the major stress hormone. We often think of it as immunosuppressive, which it is at high doses.
Right.
But it actually works synergistically with IL-6 to promote the hepatic acute phase response, helping the liver produce vital clotting and repair proteins.
So they work together.
And it goes deeper. The release of ACTH from the pituitary is actually enhanced by those very pro-inflammatory cytokines. It's a vast, complicated feedback loop designed to amplify the initial distress signal.
And the consequence of the stress response, high blood sugar, actually circles back and makes the inflammation worse.
Yes, the hyperglycemia loop.
It's a vicious cycle.
It is. The counter-regulatory hormones cause high blood sugar. That hyperglycemia itself, at the cellular level, increases the production of oxygen-free radicals, which are damaging and pro-inflammatory. It even enhances gene expression that boosts cytokine production.
So the body's emergency energy release is literally throwing fuel on the fire of the inflammatory response.
That's a perfect way to describe it.
It truly is a genomic reorganization. I mean, the source mentions the scale of this change over 3,700 genes changing expression after endotoxin exposure. That's just staggering complexity.
It is. And it underscores why developing a single magic bullet drug to fix SIRS is so difficult. The changes are complex, redundant, and highly nuanced.
Which means for now, the focus remains on
optimizing clinical care, managing the symptoms, supporting the failing organs, and crucially reducing the need for the response in the first place.
So let's do another check-in. If we look at the immense complexity of this DAMPs cascade, with the shrapnel hitting all those different receptors, what single feature of the system is the biggest obstacle when trying to design a specific, simple drug therapy to shut down that inflammatory signal early?
That would be the problem of redundancy, because DAMPs activate multiple overlapping pathways and receptors simultaneously. Blocking only one path is ineffective. The other paths simply compensate, ensuring the signal continues and making comprehensive therapeutic blockade extremely elusive.
Okay, so the body cannot sustain an overwhelming SIRS response indefinitely. It would just bat itself out. It must have internal modulators to prevent self-destruction.
Yes, it does. This is where the balancing act begins.
Let's talk about that, the pendulum of inflammation.
Correct. Almost immediately after the inflammatory trigger, the body starts to release endogenous cytokine antagonists, natural anti-inflammatory molecules. The classic examples are interleukin-1 receptor antagonist, or IL-1RA, and TNF-soluble receptors. They circulate and basically mop up or block the pro-inflammatory cytokines to limit the systemic organ damage caused by that aggressive initial inflammation.
So this moves the pendulum away from inflammation and towards the anti-inflammatory state, which we define as CARS.
Compensatory anti-inflammatory response syndrome.
Okay.
This is the body's necessary but potentially very dangerous counterresponse.
And it's regulated by its own set of cytokines like IL-4 and IL-13.
That's right. And the danger is if this anti-inflammatory state becomes too dominant or prolonged.
The patient enters a severe state of immunosuppression.
Exactly. And immunosuppression means the patient is wide open to opportunistic infection, often the kind they acquire in the hospital, a nosocomial infection.
So CARS is dangerous because the patient is no longer dying from their injury, but from their inability to fight off a secondary bacterial or fungal infection.
They're metabolically exhausted and their immune system is offline.
And if this state continues, we enter the cycle of chronic critical illness.
This is the terrifying cycle known as PIICS syndrome: persistent inflammation, immunosuppression, and catabolism.
What a mouthful.
It is, but it describes this debilitating state where the patient is just locked into a vicious cycle. Ongoing critical illness prolongs CARS, which leads to continued catabolism or wasting, and this persistent immunosuppression makes them constantly susceptible to sepsis.
So managing the balance of SIRS, overinflammation, and CARs, over-immunosuppression, is arguably the most critical component of long-term surgical survival.
It is the art of critical care.
Let's try to ground this concept with a fictional case study. Let's imagine a construction worker. Let's call him Mark.
Okay.
Mark is 45, and he suffers major trauma from a fall on a construction site. He successfully navigates the first 24 hours of massive resuscitation. They control the bleeding, they stabilize the initial catabolic shock, but he remains in the ICU for 2 weeks, requiring ventilatory support. His status eventually deteriorates despite no obvious new injury. What's likely going on there?
Mark's successful initial resuscitation conquered the shock and the immediate threat. That's the win. But his severe systemic response drove him into a prolonged period of CARs, or PIICS.
So his vulnerability is now his own immune system or lack thereof?
Precisely. His ongoing vulnerability stems from that state of immunosuppression. His late deterioration is highly likely due to a secondary insult, like pneumonia or a central line infection, which his immunosuppressed body cannot fight off.
And that triggers a fatal bout of sepsis and eventual MODS.
That's the reality behind that 25% ODS mortality rate. It's often the failure to manage the chronic metabolic pendulum, not the initial injury itself.
Okay, so once Mark is stabilized, that initial catabolic phase shifts into what's called the hypermetabolic flow phase.
The time of high energy expenditure designed for repair.
What are the key characteristics we look for in this phase, which aligns clinically with SIRS?
We see a shift toward high gear. Post-resuscitation, you'll observe significant tissue edema from those leaky capillaries and increased basal metabolic rate.
How high?
Can be 15–25% above resting values and even higher in burns. Alongside that, you see increased cardiac output, increased oxygen consumption, and hyperthermia.
Why is the engine running so hot? What's driving this?
The metabolic drivers are layered. You have central thermodysregulation driven by the cytokine cascade, intense sympathetic activity, abnormalities in energy recycling like the Cori cycle,
And just the sheer demand for healing.
the sheer demand for increased protein turnover to support healing. The body is running at an intense, high-energy but highly destructive pace.
And the most devastating result of this phase, the one that really defines chronic critical illness, is the destruction of skeletal muscle protein.
Yes, and this is where we need to introduce our next key anchor metaphor, the cellular shredder.
The cellular shredder.
Normally, muscle protein turnover is in balanced synthesis equals degradation, roughly 1–2% per day. During surgical stress, that balance is annihilated.
Oh, so.
Degradation increases massively and synthesis decreases. It's a double hit.
So tell us about the mechanism of this cellular shredder. This is crucial for learners to remember.
Okay. The predominant mechanism driving this muscle loss is the ATP-dependent ubiquitin proteasome pathway.
Let's break that down.
The process is simple in concept, but complex in chemistry. A molecule called ubiquitin acts as a tag, or a flag, that marks a specific myofibrillar protein for destruction.
Like a destroy this sticker.
Exactly. And the proteasome is a massive multi-enzyme complex that recognizes that ubiquitin tag and then breaks down the protein into free amino acids. It is literally a recycling factory, but it's recycling healthy muscle tissue to do it.
Where does this catastrophic loss occur, and what's the real danger?
The primary loss is in peripheral skeletal muscle, which leads to profound weakness, delayed recovery, and inability to ambulate.
But the more immediate danger...
Crucially, it hits the respiratory muscles. This increases the risk of hypoventilation, failed weaning from the ventilator, and severe chest infections.
Is any muscle spared?
The only silver lining, if you can call it that, is that cardiac muscle is largely spared this specific catabolic mechanism.
To put that loss into perspective, the textbook gives us a measure in nitrogen loss, which is a proxy for protein loss.
Yes, and it's shocking. Under maximal catabolism, urinary nitrogen losses can reach 14–20 grams per day.
What does that mean in real terms?
Considering that 1 gram of nitrogen represents about 36 grams of wet lean tissue, we are talking about the body sacrificing up to 500 grams of skeletal muscle every single day.
Half a kilo. A pound of muscle a day.
That is why survival becomes extremely unlikely once the body has lost 30–40% of its total protein mass.
And this leads directly to a core principle of nutritional management. You cannot force-feed your way out of the problem.
That is the key lesson. Catabolism cannot be fully inhibited by even massive nutritional input if the underlying stress, the SIRS or sepsis, continues.
So what did we used to do?
In the past, we attempted hyperalimentation, just excessive feeding. But we realized that simply creates more metabolic stress.
So what's the goal now?
Nutritional support must be adequate, aimed at attenuating the losses and providing building blocks. But the fundamental treatment for stopping the shredder is always the adequate diagnosis and treatment of the underlying inflammatory source.
Now, we mentioned that the consequence of that neuroendocrine cocktail is high blood sugar. Let's detail the mechanism of the resulting insulin resistance.
Right. The hyperglycemia that develops post-injury is caused by a massive increase in glucose production from the liver,
Thanks to the counterregulatory hormones.
combined with a profound decrease in glucose uptake in peripheral tissues. And that's the resistance part.
Why are the muscles and fat cells suddenly ignoring the insulin signal? What's going on?
The primary culprits are the pro-inflammatory cytokines. They're highly disruptive, they interfere directly with the signaling pathways, and they reduce the responsiveness of the insulin-regulated glucose transporter proteins.
The doors on the muscle and fat cells that let glucose in.
Exactly. The cells are essentially locked and refusing to uptake the available glucose from the blood.
And like everything else in this response, the duration is proportional to the injury.
Yes. After routine abdominal surgery, insulin resistance may last about 2 weeks. But with sepsis and a chronic critical illness, it can be much longer,
And that puts the patient at risk of all the complications associated with uncontrolled high blood sugar.
including perpetuating that inflammatory loop we discussed earlier. It becomes a self-fulfilling prophecy.
So critical care teams have to actively manage this.
They do, usually through continuous intravenous insulin infusions to maintain blood glucose within acceptable limits. This tight control has been shown to reduce overall morbidity and mortality.
But it's a fine line to walk.
It's a very delicate balancing act because overly aggressive control risks significant and often fatal hypoglycemia.
Okay, another check-in question then. We've covered the sacrifice the body is making, the 500 grams of muscle loss daily, the reliance on the cellular shredder. It seems incredibly destructive. Why is the body willing to sacrifice so much protein so rapidly and aggressively? Isn't that counterintuitive?
It feels counterintuitive, but it's the ultimate act of reprioritization. The muscle breakdown provides essential labile protein reserves,
So readily available protein.
specifically key amino acids like glutamine and alanine, and these are indispensable for the survival of the prioritized central tissues.
Such as?
These amino acids are fuel for the liver to manufacture vital acute phase proteins. They're fuel for the immune system to fight infection. And they are the necessary building blocks for the wound site to facilitate healing. The body views peripheral muscle as sacrificial fuel for system survival.
And this concept of reprioritization is perfectly illustrated by the drastic and often very misleading changes in overall body mass and fluid distribution.
Absolutely.
Let's quickly review the composition of a standard 70-kilogram male.
Right, so you have about 57 kilograms of lean body mass, which includes 42 liters of water, 12 kilograms of protein, and 3 kilograms of minerals, plus about 13 kilograms of fat.
And the distinction between the reserves is key here.
It is. Fat is the readily available energy source. Skeletal muscle is the main labile protein reserve. Losing fat is manageable. Losing large amounts of protein mass leads to major functional deficits, reduced strength, and the depletion of visceral proteins needed for critical function.
And we must contrast major injury and sepsis with simple starvation. They are not the same thing.
Not at all. Starvation is an adaptive state. Nitrogen loss is attenuated. The body conserves muscle by shifting metabolism to ketone bodies.
But after major injury,
That adaptation fails, it breaks down.
Right.
This leads to the ongoing auto-cannibalism and those massive nitrogen losses. The loss of 10, 20 grams of nitrogen a day because the immune system and the liver are screaming for glutamine and alanine, and the body must provide them regardless of the consequences to the muscle.
and this leads to the strange paradox of the critically ill patient actually gaining weight.
This is such a vital point for clinical learners. Critically ill patients often show an increase in total body weight immediately post-resuscitation.
How much of an increase?
Often 6-10 liters of weight gain within 24 hours. And this is due to a massive, rapid expansion of extracellular water.
So it's all fluid.
It's driven by fluid resuscitation combined with those leaky capillaries from the SIRS response. And this fluid retention masks the simultaneous catastrophic loss of functional fat and protein mass. The weight gain is bad plumbing. It's not a reflection of nutritional status.
The liver then acts as the priority triage center for all these incoming amino acids. Despite its small size, its turnover rate is incredibly fast.
It's 10-20% of its protein content per day. It's a powerhouse.
And pro-inflammatory cytokines, particularly that workhorse cytokine IL-6, promote the synthesis of specific proteins at the expense of others.
This is the acute phase response, and is truly a double-edged sword for the patient's status.
So what's on the good side of the sword, the positive acute phase proteins?
These are proteins whose concentration increases in the blood. Fibrinogen and C-reactive protein, or CRP, are the two major ones.
And they are important for.
Fibrinogen is essential for clotting. CRP is a key marker of inflammation and aids in defense. Their increase is vital for repair and containment.
And on the negative side, the proteins that fall.
These are the export proteins, most importantly albumin. Its plasma concentration falls acutely and clinically. Low albumin is a very poor prognostic sign.
Now here's the critical nuance. Is the liver simply stopping albumin production, or is something else happening?
That's a great question and a common misconception. The drop in albumin is generally not due to the liver slowing production significantly.
What is it?
It is principally due to a massive increase in the transcapillary escape rate, or TER.
The leaky pipes again?
The leaky pipes again. Because of the inflammatory response, the microvascular permeability has increased dramatically. Albumin, which is a large protein, leaks rapidly out of the blood vessels and into the swollen extracellular space. The TR can increase threefold after major injury.
So the factory's running, but the pipes are leaking furiously.
That's the perfect analogy.
We've established the inevitable systemic reaction, the DAMPs, the hormones, the catabolism. But what the core text really emphasizes is that good perioperative care relies on identifying and eliminating the avoidable factors.
Things that needlessly amplify the stress response and keep the patient in a prolonged catabolic state.
These roadblocks, listed in Summary Box 1.8, must be actively managed.
They must. They include ongoing volume loss, hypothermia, starvation, and immobility. Dealing with them is the essence of modern surgical recovery protocols.
Okay, let's start with volume loss, which triggers the AD-aldosterone axis.
Right. Pain signals and any degree of blood volume loss immediately activate the system. This leads to the release of antidiuretic hormone, ADH, and the renin-angiotensin-aldosterone system.
And the result?
The result is rapid conservation of salt and water by the kidneys. This causes the natural oliguria, or decreased urine output, that we expect to see post-surgery.
The problem is when medical teams, often out of caution, over-resuscitate with too much intravenous saline.
Exactly. That excess fluid, combined with the leaky capillaries of SIRS, cannot stay within the blood vessels. It leaks out, causing peripheral edema, but more damagingly, visceral edema.
Swelling of the gut walls.
Swelling of the gut. And this gut swelling significantly delays gastric emptying, prolongs the resumption of feeding, and thus lengthens hospital stay and catabolism.
So the modern goal, particularly in elective surgery, is
to avoid net weight gain. It means careful, often restricted, fluid management.
Okay, next roadblock, hypothermia. This seems so simple to fix, but the metabolic consequences of being cold are staggering.
They're profound. Even mild, subtle hypothermia triggers increased production of adrenal steroids and catecholamines. The body thinks it's freezing, so it ramps up the stress response.
And the data on this is clear, right?
Oh, very clear. Studies show that compared to normothermic patients, mild cooling leads to a 2- to 3-fold increase in postoperative cardiac arrhythmias and significant increases in overall catabolism.
So maintaining core temperature is a powerful metabolic intervention.
Absolutely. Randomized trials confirm that simply maintaining normothermia, often using forced air warming blankets, dramatically reduces wound infections, minimizes cardiac issues, and even reduces bleeding and transfusion requirements. It's a simple, high-impact method of reducing surgical stress.
Let's move to starvation, which is highly relevant given historical surgical practices. We used to fast patients for a ridiculously long time pre-op.
We did. Nil by mouth from midnight.
And the problem with that is the brain requires an obligate 100 grams of glucose per day.
It does. In a fasted state, the body runs through its glycogen stores in about 24 hours, and then it is forced to engage in hepatic gluconeogenesis, making new glucose, primarily from those precious muscle amino acids we just discussed.
It immediately accelerates the catabolism.
Right. So simply avoiding unnecessary fasting is protein sparing.
And the text points out that supplying just 80 grams of glucose, which is the equivalent of 2 liters of standard high-V dextrose, has a significant protein sparing effect.
It does. And this is the rationale behind modern preoperative guidelines, allowing clear fluids up to 2 hours before surgery and the use of carbohydrate loading drinks.
What does that pre-op carbohydrate drink specifically achieve metabolically?
Well, besides reducing thirst and anxiety, It stabilizes the patient's baseline glucose reserves, and most importantly, it significantly attenuates or reduces the degree of postoperative insulin resistance they will experience.
So you are starting the major stress event with a much less stressed metabolic profile.
You're starting on a much better footing.
Finally, the simplest yet most ignored catabolic driver, immobility. The traditional doctor's instruction to stay in bed is actually damaging.
It is a potent stimulus for muscle wasting. Inactivity directly impairs the normal mechanisms where meal-derived amino acids stimulate protein synthesis in skeletal muscle
If the muscle is inactive, the body assumes it is surplus to requirements.
and feeds it to the cellular shredder.
So the intervention is intuitive.
Active early mobilization is essential. Moreover, we are now seeing the rise of prehabilitation programs, where patients optimize their fitness, mobility, and nutritional state before major elective surgery.
Giving the patient a better metabolic reserve and baseline functional capacity to weather the storm.
That's the goal.
All of this complex science, understanding the mediators, the catabolism, the hormonal shifts, and these avoidable stressors, it all culminated in a major paradigm shift in surgical care.
Known as ERA, Enhanced Recovery After Surgery.
And this is the practical, evidence-based culmination of this entire chapter, isn't it?
It is. It's a multimodal approach, a coordinated attack using multiple interventions at once, aimed explicitly at reducing the magnitude of the homeostatic stress response and, critically, minimizing catabolism.
And the results really speak for themselves.
They absolutely do. ERS protocols, when rigorously applied to major surgery, routinely achieve reductions in hospital stay of 30–50% and show better clinical outcomes. It's the most effective known way to actively mitigate the need for this hypermetabolic response.
So let's summarize the 5 core pillars of ERS, derived directly from the source's understanding of the stress response. First, minimizing the insult.
That means use of minimal access techniques, like laparoscopic or robotic surgery. The smaller the wound, the less tissue trauma, the lower the damp release, and the less intense the inflammatory cascade.
So a simple reduction in tissue handling pays huge dividends metabolically.
Huge.
Second, afferent blockade, tackling the pain signals that initiate the neuroendocrine cascade.
Right, blocking the nociceptive signals from reaching the hypothalamus. Historically, this involved highly effective methods like epidural analgesia, which blocked both pain and the resultant cortisol stress response.
But that's changed a bit with smaller wounds.
It has. For modern, smaller wounds, teams often use adjuncts like one-shot spinal dimorphine or continuous intravenous lidocaine infusions. These are opiate-sparing, improve gut function, and avoid some of the side effects of prolonged epidurals.
Third, nutrition.
Minimal preoperative fasting periods, utilizing carbohydrate loading, and ensuring rapid, early oral or enteral feeding immediately after the operation. Getting the gut working early is crucial to shifting the patient toward anabolism.
Fourth, fluid management.
This is strict avoidance of excessive intravenous saline. The goal is goal-directed fluid therapy, avoiding that massive expansion of the extracellular space and the resultant visceral edema that cripples gut recovery and prolongs discharge.
And finally, rehabilitation.
Early, active mobilization, avoiding bed rest entirely, and emphasizing prehabilitation to maximize the patient's metabolic reserves before the stress even begins.
It's remarkable how controlling these systems can have benefits that stretch way beyond the recovery room.
Indeed. The text notes that even pharmacological modulation, like the use of ball blockers after major surgery, has been associated with improved short- and long-term survival.
And the theory is?
The theory is that they modulate the hyperadrenergic state induced by surgery, essentially controlling the harmful chronic phase of the neuroendocrine response. This shows we're moving beyond just treating the wound to treating the whole metabolic human being.
That was a deep and, I think, essential dive into Chapter 1 of Baily and Love. We've really dissected the body's emergency operation. Before we close, let's briefly review the 3 most critical components of the metabolic response that should stick with you, acting as your mental anchors.
Okay. First, remember the initial trigger, the inflammatory component driven by DAMPs, which we call the cellular smoke alarms, leading to SIRS.
Second, the fast systemic emergency manager. The neuroendocrine counter-regulatory hormones cortisol, adrenaline, and glucagon released from the HPA axis. The cocktail.
And third, the engine of destruction, fueled by the breakdown of muscle, the subsequent catabolism driven by the ATP-dependent ubiquitin proteasome pathway. our anchor metaphor of the cellular shredder, sacrificing protein reserves for survival.
The ultimate lesson here seems to be that a patient's survival and subsequent recovery are determined not just by the surgeon's skill in fixing the primary injury,
No.
but by how successfully the entire team manages that resulting catabolic crisis, that dangerous Surscar's pendulum, and critically, how well we eliminate those controllable factors like hypothermia, starvation, and over-resuscitation.
And if you are using this as a study aid, please utilize the structure and the anchors we discussed, the cellular smoke alarm, the shredder, the counter-regulatory cocktail, as a guide to recall these complex pathways.
But always, always read the definitive text for full context and depth.
Absolutely.
And to leave you with the final provocative thought, let's revisit the role of genetic variability.
Right. We know the intensity of both the SIRS and CARS responses varies widely between individuals because of their genetics.
And our current gold standard, ERAS, is based on multimodal population-based evidence.
It is. So how might this individual variation change the future of perioperative medicine? Could genomics allow us to screen patients preoperatively, predict which individuals are most likely to develop a catastrophic CARS or PIACS syndrome?
And then tailor our interventions.
And then tailor our stress-modulating interventions, our fluid, our nutrition, our pharmacological strategies, specifically for that patient. Understanding and leveraging this inherent variability is truly the next frontier in improving surgical outcomes and survival.